I don't think that we can say that there is a single best test at this point. We have several options that all seem to work well. We are awaiting the publication of studies that compare colonoscopy with fecal immunochemical testing. But I predict that in those studies, the participation rate of patients and whether they adhere over time will be a big determinant of the results. So we have the tests and how they perform, and also whether patients do them. The decision then comes at several different levels. One is at the level of national screening programs or national guidelines, whether based on local resources, it's possible to offer more than one alternative, or whether there really is a leading choice. So in some places, the decision may be made that it has to be a non-invasive fecal immunochemical test, for instance. Others may offer choice, including that or colonoscopy, or what are currently more costly tests like the stool DNA test. I think the same questions will apply to emerging blood-based tests. How well will they perform and how much will they cost? And then at the level of the individual patient, if there is choice, then I think there's room for patient preferences. So to summarize, in my mind, it is much more important that patients adhere well over time with whatever program they choose, that the test be done reliably, and that when there's a colonoscopy, whether it's the primary colonoscopy or a follow-up colonoscopy, that it be done with quality. These things are probably much more important than specific differences between tests. If future research does show that one strategy is unequivocally better than another one, then we'll have to view it differently. But at this point, I think choice matters, quality matters, and the most important thing is that the patient participate. The World Endoscopy Organization is very interested in promoting research in many areas. For some of the questions related to surveillance, we have initiatives based from WEO, but also it's a forum for investigators to come and share their research and their own ideas. Some of the efforts that have sprung up from the WEO include systematic reviews of the data on the yield of surveillance, depending on the baseline neoplasia risk. But also there are the reports of ongoing studies, and those depend on individual doctors' creativity. My advice to young investigators would be to consider the following questions. One is, why do we still see interval cancers? Why do we still see interval cancers at higher rates in some patients? How much is that due to the biology of those individuals versus what we missed at previous colonoscopies? What is the role of interval testing with non-invasive tests? And can we individualize the surveillance strategies for different people depending on their screening history and the findings? Those are the types of questions that I think could move the practice in surveillance in the future. So any young investigators thinking about fruitful areas for research, I would urge them to consider those.